A very good afternoon to all of you. It's my pleasure to be here. I thank Professor Muhammad for inviting me to be here. And today I'll be speaking about injectable and oral GLP-1 RA in Ramadan month. So I would be discussing quickly about the various advantages of oral GLP-1 RA, the evidence that we have today, and the special guidance that need to be given with some of these molecules. So if you look at the fasting month of Ramadan, we see that majority of our patients with diabetes choose to fast during the month of Ramadan despite their medical conditions. And because of this, we need to educate them prior to the month of Ramadan about the various precautions that they need to take and also adjust the therapy so as to see that they are at a low risk of hypoglycemia. And hypoglycemia remains as a major challenge for people with diabetes. And in addition to that, the change in sleeping and eating habits, the pre-dawn and sunset meals also cause a little disturbance. And the changes in duration of fasting, which happens across different years, is also a challenge in managing diabetes in our patients who choose to fast. Now, when you look at the choice of medications, often the preference is therefore for medications which have a lower risk of hypoglycemia, and incretin based therapies particularly suit this requirement very well. And they stimulate glucose dependent insulin secretion, have a very low risk of hypoglycemia even during the fasting hours, and they do not require significant changes in the dosage or timing of administration as compared to all the other different therapies that are available, and hence they are a preferred choice in our patients with diabetes. So if you look at the metabolic abnormalities that are corrected by GLP-1, because GLP-1 are a unique group, RAs are a unique group of molecules that are addressing, you could say, 6 or 7 out of the different pathophysiological abnormalities which are contributing to diabetes, the ominous octet, which we call. So 7 of these abnormalities are tackled by GLP-1 RA. As you can see here, they not only reduce increase insulin secretion, they reduce the glucagon secretion, they alter the neurotransmitter. I mean, they correct the neurotransmitter dysfunction and all the other benefits that they have. Because of this, they are very well used molecules for glycemic control, and also they have additional benefits of providing cardiovascular and renal benefits in our patients with diabetes. If you look at the spectrum of GLP-1 RA available today, we have once daily preparations like lexasenatide or liraglutide, and then we have the once weekly injectable molecules like dulaglutide and semaglutide and exenatide extended release one. And you also have now we have the oral semaglutide, which has been a game changer, and it is to be taken once a day every morning, 30 minutes before a meal, while the others do not require any specific preference and can be taken injectable. The injectable ones can be taken at any particular time of the day. Now, the advantage of GLP-1 RA is that they have shown to be have proven clinical efficacy in terms of reducing HbA1c levels, having a favorable effect on the body weight, in fact causing a significant reduction in the body weight. They have a low risk of hypoglycemia as a monotherapy. They have cardiovascular benefits, and it is very simple prescribing them because they can be prescribed even very easily during the month of Ramadan. And the only major problem is in terms of the GI disturbance that is seen in many of our patients, which is particularly more during the initial few weeks and then subsides later on. So now let me walk you through the evidence available with the different molecules, the GLP-1 RAs that we have today. One of these studies was the one which I was a part of this study. This was which was looking at the safety of lexasenatide plus basal insulin treatment regime in people with type 2 diabetes across the world. And this was a post-hoc analysis of the Indian patients, because we had majority of the patients in this study were from India, and we did a post-hoc analysis of the Indian patients from the Indian subcontinent, and I will share the results of that in this presentation. So this was a not a treat to target study, but patients who were on with type 2 diabetes for more than 1 year, who were insufficiently controlled with sulfonylurea and basal insulin, plus or minus any additional oral anti-diabetic medication, were randomized to either receive lexosinatide in place of the sulfonylurea or continuation of sulfonylurea. So we had 75 patients in each arm, and these patients were enrolled 6 to 12 weeks prior to Ramadan, and then they went through the fasting month of Ramadan, and then we had a 1 month of post-Ramadan follow-up of this. The primary endpoint in this study was looking at the percentage of patients with type 2 diabetes who experienced documented symptomatic hypoglycemia during Ramadan month. So if you look at the baseline characteristics, they were pretty similar between the two groups. They had a duration of diabetes of almost close to 6 years, with a HbA1c of close to 8.5% at the initiation of therapy. And if you look at the primary endpoint of the number of patients who experienced more than one hypoglycemia, it was only seen in about 1.3% of patients in the lexosinatide arm, as compared to 6.8% in the SU arm. And if you look at if you look at the breakup of the hypoglycemia during the whole treatment period, it was 1.3%. During the Ramadan fast, it was again 20% in the SU plus BI arm versus 14.7%. If you look at one of the advantages of lexosinatide was that during the fasting hours, we did not see any patient developing hypoglycemia with lexosinatide. The only patient who developed hypoglycemia was after the fasting hours, and so it becomes very easy for managing such a hypoglycemic episode. Most of the patients were able to fast throughout the month of Ramadan, and they did not need their increase in their dose of SU. SU dose was adjusted as per the standard recommendations. And if you look at the HbA1c reduction, there was a better reduction in the HbA1c with the use of lexosinatide as compared to SU, and there was a reduction in the body weight also, which was greater in the group that was receiving lexosinatide as compared to SUs. And if you look at the treatment emergent adverse events, this was higher in the lexosinatide group, however, but these were mild GI disturbances which settled down over the period of the fasting period, over the period of the study, and they did not cause any patient to be withdrawn from the study. So in summary, we see that there was a numerically lower incidence of documented symptomatic hypoglycemia in the group that was receiving lexosinatide as compared to the SU arm, and no participants with hypoglycemic episodes during the fasting hours, and no episodes of severe hypoglycemia. So this makes it a very suitable molecule. If you look at the liraglutide study, which was a similar study, we're looking at a comparison of liraglutide versus SUs in patients who were on metformin SU and were randomized to either of these two arms. Again, you had a higher number of patients in this study. We had 172 patients in each of these arms, and the dose of SU in the group that continued SU was adjusted as per the standard recommendations. It was brought down during the Ramadan month and brought back to the pre-Ramadan levels after the Ramadan month. The primary endpoint, however, in this study was the change in fructosamine from the beginning to the end of the Ramadan period, and so this was because the fructosamine is a better indicator of a short duration of glycemic control, and the secondary endpoints being the HbA1c, the effect on HbA1c, the fasting plasma glucose, the body weight, and the episodes of hypoglycemia. So 172 patients in each of these two arms, and most of them, there was no difference in terms of the number of people who could complete the study, and there was again decline in the fructosamine in both the groups, similar reduction in both the groups, numerically slightly lower with the SU as compared to liraglutide, but when you look at the changes in the fasting plasma glucose levels, it was better with liraglutide, and similarly better reduction in HbA1c with liraglutide, and lower episodes of hypoglycemia, whether it is documented symptomatic episodes or confirmed hypoglycemic episodes. They were lower with liraglutide as compared to the group on SUs. And there was no episode of confirmed nocturnal hypoglycemia in the liraglutide arm as compared to SUs. This is probably one of the major benefits of this molecule. Hypoglycemic episodes, if you see the distribution of hypoglycemic episodes, you can see clearly that there was lower number of episodes in each of the categories, whether you look at confirmed hypoglycemic events, or whether you look at documented symptomatic hypoglycemic events, or whether you look at a severe hypoglycemia. And the change in body weight again is in favor of the use of liraglutide as compared to SUs. And if you look at the percentage of patients reaching a composite target of a reduction in HbA1c to less than 7 without weight gain, without hypoglycemia, you see that significantly higher number, almost close to 55% of the patients receiving liraglutide reach this composite target as compared to just about 20-25% in the SU arm. So once again, the major difference, I mean, one of the differences was in terms of the adverse events of mild GI disturbances, which are known to occur with this class of drugs, and that was higher in the liraglutide arm as compared to the SU arm. But again, it did not lead to any withdrawals from the study because of these AEs. And overall, the treatment satisfaction, patients were satisfied at the end of the treatment period. They were more satisfied. Those in the liraglutide arm had more satisfaction scores as compared to those with SUs. Now, coming to the other molecule, which is probably a game changer in terms of making these injectable molecules available as, in oral preparation, is oral semaglutide, which is semaglutide bound to the SNAC protein, which promotes the semaglutide absorption across the gastric epithelium, and it enhances the availability of oral semaglutide. So this molecule has been shown to have similar efficacy as compared to different classes of oral or injectable anti-diabetic medications, and it is proven to have glycemic benefit across the spectrum of diabetes. As you can see from the entire Pioneer program, we have a lot of information available about this class of drugs, this molecule, and we also see that the benefit in weight is similar or probably better than that which is observed with even injectable once weekly semaglutide. Now, this molecule has certain requirements in terms of of enhancing the absorption of this molecule, and hence we had come out with this review article recently, which was published very recently, on the recommendations for titration and administration of oral semaglutide for the treatment of type 2 diabetes during Ramadan, in which we highlighted the need for initiating oral semaglutide at least 6 to 8 weeks prior to the month of Ramadan to reach an effective dose of 7 milligrams if you are planning to prescribe this to your patients who are going to fast during the Ramadan month. Using it even earlier is better in terms of reaching the titration point of 14 milligrams, which is the most effective dose of this molecule. But however, you would not suggest up titration of the dose within 2 to 4 weeks prior to Ramadan, or even during the Ramadan month, because that can lead to significant changes in terms of the nausea that happens whenever the dose is titrated, and that can be a problem during the month of Ramadan. The preferred timing has been given by consensus. We have discussed and come to a conclusion that it would be best to prescribe this molecule to be taken immediately after, in the iftar period, immediately after breaking the fast. They could take the oral semaglutide, then wait for 30 minutes during the Maghrib period, and then before the iftar meal, so that period ensures the absorption of oral semaglutide. However, we have also highlighted in this review about the fact that there could be a challenge in terms of, when a person is also on levothyroxine administration, there can be a challenge in terms of, providing this time period for the absorption. And we have suggested that levothyroxine could, in that situation, be used in the night post-dinner, 3 to 4 hours post-dinner, so that it does not interfere with the absorption of semaglutide. We have also discussed about the various deviations that can happen and what is the effect of these deviations, which could impair the absorption to a certain extent, and we have highlighted the best practices that need to be followed for the use of oral semaglutide during the month of Ramadan. Now, coming to the other study, which has looked at the use of this fixed dose Iglar Lixi, that is glargine with lexacentide, This was or which is called a Soliqua. We have studied this in two consecutive Ramadans, that is Ramadan of 2020 and Ramadan of 2021. And this was again a multinational study across different countries with more than 400 participants being enrolled in this study, and particularly from the Northern African and the MENA region and Indonesian region. The primary endpoint again here was the incidence of hypoglycemia, documented hypoglycemia, symptomatic or severe hypoglycemia, and these rates were once again found to be very low, 2.3% during the fasting month of Ramadan, 1% in the pre-Ramadan month, and probably 0.3% in the post-Ramadan follow-up period. So we see that this molecule, again, if you look at instance of other hypoglycemic events also, again, you see that it was similarly low across the entire study period, and you could see favorable effects on the HbA1c, and the number of patients reaching the target of less than 7% was close to 30%. With the changes in the fasting plasma glucose and body weight were again favorable with the use of this molecule. So I would like to summarize in the end, saying that I think I've been able to convince all of you that GLP-1 RAs have unique benefits as anti-diabetic therapy during the fasting month of Ramadan. They have the unique benefit of causing very low risk of hypoglycemia. They have a favorable effect on the body weight, and these probably are the two major benefits which make these molecules very useful during the month of Ramadan. We have studies with lexasenatide and liraglutide, and we also have a study with the fixed dose combination of lexasenatide with basal insulin, which is again highlighting the safety of this, or reconfirming the safety of this molecule during the month of Ramadan. And oral semaglutide, which has unique advantages, can also be used during the month of Ramadan, but there could be challenges in terms of its the timing of administration. That has to be discussed with the patients, and they need to be educated about this. With these with this care that we take, we would be able to provide a very good benefit to our patients in terms of a good glycemic benefit with very low risk of hypoglycemia, so that they can safely fast during the month of Ramadan with the use of molecules like the GLP-1 RAs. Thank you all for the patient hearing.